Right, so we didn't miss much. So recording, yes, counseling a chronic disease patient begins with introductions. You introduce yourself as a medical student, ask the patient's name and age. You may ask about their occupation and just gain consent for them to go go along with your line of questioning. You can let them know that you're here to speak to them about your hypertension, diabetes, heart disease, whatever the case might be. All right. The second important thing you need to do is clarify the reason for the visit. So notwithstanding whatever is written on the instructions before you enter the room in an OSCE sort of setting, you need to find out from the patient their reason for being here. So you may say something like, "I am aware that you are hypertensive and have come for a review. Is that, can you confirm that is the reason for your visit?" And they may do just that, or they may add something more to their reason in terms of a complaint that they may have, or a side effect of a medication they may be experiencing, or some concern that may not have been overtly disclosed on the instruction sheet that appears on the door before you enter the examination room with the patient. The next part is what the students do pretty well at. This is exploring the disease component of the consultation. Those of you who would have looked at Professor Maharaj's patient-centered consultation, you will remember or recall that you need to explore the disease in terms of taking certain components of the history, in particular the past medical history. They want to find out how long they've had their chronic disease, diabetes, hypertension, whatever, and any other comorbidities. Remember that chronic diseases often exist in the form of a syndrome, like the metabolic syndrome, where if it is that you're hypertensive or diabetic or vice versa, then you're likely to have a number of other comorbidities, including things like dyslipidemia, central obesity, insulin resistance, overweight, hyperuricemia, and so on. And so you need to ask about the presence or absence of other comorbidities, and especially duration of that particular chronic disease. In terms of your drug history, Ryan is asking if I'll be getting this PowerPoint. You should be. I posted it on my e-learning. So I'll check again after the presentation, right? But it should be there. Just check under week 3. The drug history, names of medications and compliance. So you need to find out from the patient, in their words, what are the medications they are currently taking for their chronic disease. And very importantly, whether or not they are compliant with it. So because they tell you they have been prescribed X, Y, and Z, doesn't mean that they're taking it. And they need to find out whether the compliance is in accordance with the prescribed quantities and frequencies and dosages prescribed by the physician. Sometimes patients do their own thing. You know, you may have relatives, or you may have friends, or you may have directly interacted with chronic disease patients who tell you, yeah, I'm taking my lisinopril or I'm taking my metformin, but they're taking it how they want to say, well, you know, take it whenever they feel a certain way, or they may be taking it once a day instead of twice or 3 times a day as prescribed, and or they may be taking it at variance to the instructions regarding when they should be taken with meals and so on. So you need to find out if they're compliant and to further quantify their compliance as it relates to the frequency and timings of their medications. And of course, if they tell you they're not compliant, you need to find out why. And you'll find that that tends to be a big problem in chronic disease patients, getting them to be compliant with their prescribed regimes. And the reasons for the non-compliance could be a number of things. It could be things related to the medication itself, side effects or fear of side effects, or it could be not related to the medications. You know, some altered concept or misconception of the actual chronic disease that you are trying to treat. I think we made the point in asthma that some patients may actually discontinue inhaled steroids and so on when the asthma begins to become more controlled. and therefore render themselves susceptible to exacerbations or loss of control based on the fact that they are not aware of the chronicity of their condition and the need for medications to be taken regularly and daily until otherwise instructed by the physician. Sometimes the reasons they're not taking their medications could be as a result of costs. Cost factors may be prohibitive, or availability factors for whatever reason. They are unable to access the drug. It might be out of stock at the health center or at their local pharmacy. And so we need to inquire about availability, accessibility of the medications as well. All right. So very important to find out about drug compliance. Family history, we know that amongst chronic disease patients, there exists a strong familial component for most, if not all of them. So we know that hypertension tends to be more common in certain ethnic groups, African people, diabetes in Indian people, but even more so amongst first-degree relatives. So we want to find out about family history of the chronic condition or disease, and whether or not anyone from their family suffered a complication arising out of their chronic disease. So you might find that amongst people with multiple hypertension or diabetes, they may have had sudden cardiac death, or you might have had a strong history of heart disease or stroke or peripheral artery disease as a consequence of the large numbers being affected in their family by those chronic diseases. In terms of social history, you must ask about cigarette smoking, alcohol consumption, diet, and exercise. So cigarette smoking, as you might recall from the Smokers Association lecture, you want to find out, how long have they been smoking, how much do they smoke, when do they smoke, and so on. Previous quit attempts as well. Alcohol, you want to quantify the type of alcohol, the frequency at which it is consumed, and the quantity. Right, diet, of course, very important, especially for hypertension. You want to find out about their sodium intake. You probably hear from Dr. Clapperton what sorts of diets are in keeping with low sodium and reduce or that are useful for controlling blood pressure. You might hear about the DASH diet. Right, in terms of diet and diabetes, you want to find out about what their meals look like, how many times a day do they eat, do they take snacks, what do those snacks consist of, are they unhealthy, or are they on healthy snacks consisting of fruits and vegetables, or unhealthy snacks with a high caloric intake, such as those snacks that or foods that are high in carbohydrates, starches, and trans fats. So you want to find out about their diet and, of course, exercise. And a lot of patients tell you they exercise but are unable to really prove to you that they're exercising. So you need to find out what type of exercise they're engaging in and the frequency at which they engage. So some people might just say, well, they do housework. But when you find out from them, the housework or the garden might just be sporadic once every week or two. So it might not be extensive exercise. So you want to find out whether or not it's preferably aerobic exercise. Aerobic being any kind of exercise that gets the heart rate, increases the heart rate and the duration of the exercise. And according to WHO guidelines, which recommends 30 to 45 minutes of aerobic exercise most days of the week. So they need to find out if they're meeting that standard. And of course, if they're not exercising, whether or not there's a valid reason for it. Perhaps it could be that they have osteoarthritis that precludes their ability to exercise because of the pain and so on. Right? So these questions, you tend to let the patient tell you about it, more open-ended, and you guide the discussion regarding the quantities, the timing, the frequencies, and so on. This part of the chronic disease counseling is not done too well. This one relates to the illness experience. So Professor Maharaj might have spent some time speaking about the 5 and how we go about exploring the illness experience using the 5 acronym. So it stands for feelings, ideas, functions, and expectations. So one of the main comorbidities associated with chronic disease or chronic diseases is actually mental health issues like depression and anxiety. So very often you'd want to find out the mood of the patients who have a chronic disease. So how do they feel most of the days? Happy, sad? Is there any anhedonia or loss of interest? So answers to those two questions, sadness and loss of interest, are associated or have a high positive predictive value for for diagnosing depression or having a depressed mood. And so we know that depression, while it is highly correlated with chronic disease, can have adverse effects as it relates to the patient's own levels of motivation, their ability to comply with prescribed treatment, and to self-monitor. So you want to spend some time finding about how the patient feels about their chronic condition. Is there anything and unresolved feelings regarding their chronic disease, especially as it relates to their mood? All right. The other component is their ideas. What do you understand by the chronic disease? So their idea of hypertension or diabetes might be totally at variance to what is correct or what might be your understanding of it. So a lot of patients might tell you, well, doc, I'm not really diabetic, I have a trace of sugar. And, that really doesn't give much in the sense that it doesn't tell us what exactly the patient is suffering from. Is it that they're speaking about pre-diabetes? Is it that they had one reading that was off and then or erroneous and then returned to normal thereafter? Or is it that they're frankly diabetic and then a bit in denial? So you need to find from them what do they understand by having hypertension or diabetes, and then if their view is not in keeping with what is accurate, you simply begin to counsel them about what diabetes is and the fact that it's a chronic condition that cannot be cured, but that can be managed using a combination of lifestyle changes and therapeutics. Function, the second F has to do with how the chronic disease has affected the function of the patient. So specifically, how has this affected the daily life? Are you able to perform a normal societal role as whatever your occupation is, or even at the home level as a father, mother, son or daughter? Are you able to perform the daily activities associated with living, caring for yourself, and so on? Somebody's asking if the slide's moving. It should be on the 5 slide. Has everyone seen the 5 slide? All right, so yes, so Jelani, it might be a problem with your connection. All right, so you want to find out, as a patient functioning at work, do they have missed days of work or school, as was exemplified in the case of asthma? Sometimes if the asthma is uncontrolled, they spend a lot of time in hospitals or at home nebulizing, and therefore they're unable to complete their normal societal role as a student or as a worker. At home, is it that they're able to take care of themselves and their family, or is it that they're rendered somewhat disabled by virtue of any complications that arise out of having a chronic disease? For example, they may have suffered an amputation as a result of diabetes or loss of vision, and that has compromised their ability to do certain tasks. And you need to find out from them in what regard that is the case. The ENE5 speaks to expectations. So don't assume that what you're going to counsel them about is what the patient expects. So what we generally ask here is ask the patient, what are the expectations arising out of our consultation here today? Is there anything specifically I can assist you with? And you might be surprised, it could be some specific issue they have regarding their chronic disease, like a spike in their morning or evening blood sugars, or spikes in their blood pressures, as an example, where they may need some guidance specifically. So you need to ask that question specifically in terms of eliciting the expectation. So this is what the illness experience is, and how we inquire about it. Know that the answers to the above must be personalized and appropriate, so that you don't give advice in a general sense, but rather specific to the patient. So if it is that the patient has some loss of function, as it relates to, let's say, their ability to walk long distances, you would want to be able to find out the reason for not being able to walk long distances. So if they say osteoarthritis, then you might want to offer them the swimming as an option. If, however, it's a circulatory problem where they experience pain, something called peripheral artery disease or critical ischemia, then the issue is different. It may very well be that they need to have further lifestyle modifications and even certain medications like pentoxifylline and so on to help augment their circulation so that they could walk longer distances and so on. So it needs to be personalized based on the responses they give to you and not given in a generalized sense. A big part of the patient-centered clinical method or model has to do with mutual and realistic decision-making. So after you have explored both the disease and the illness experience, your job as a primary care physician or family physician is to negotiate with a patient a reasonable course of action that is mutually acceptable. So some of the terminologies or the wordings you would use to gain that patient's trust and cooperation with things like, we can look at ways to improve their compliance by, so you're not going to tell the patient they have to take their medications twice or 3 times a day, and they must take drug X, Y, and Z, but rather we can improve your compliance by perhaps using combined drugs, where they combine different classes so they're less likely to forget. Or we could suggest they get a pill box and have their medications packaged out on a Sunday by themselves or a child or some responsible person, so that they can then ensure that their medications are taken with less likelihood of forgetting. It can improve their diet bias rather than telling them they need to omit completely in an absolute sense. You could tell them that they need to reduce the intake of certain starchy foods and perhaps replace them with more healthy foods like fruits and vegetables. So rather than being paternalistic and absolute and telling them they cannot ever eat mangoes or watermelon or chocolates, you can say what you could reduce the intake of that and replace it with perhaps 1 block of dark chocolate and more fruits and vegetables and so on. All right. So sometimes they may not like a certain type of food, but you'll be able to give a suitable alternative. So if you, for example, tell them that they should or not eat white rice or white sada roti, you could probably then offer them something like brown rice, and they may say, well, I don't really like brown rice, and then you could offer a third option like provisions and so on. So maybe you can. You see, these are terminologies you're using rather than you must or you have to. If the medicine is giving you side effects, we can consider changing it too. So a common example here would be like if it is that the patient is developing a dry cough because of ACE inhibitor use, you may want to then suggest to them that because the dry cough isn't class specific, with enalapril, for instance, that they can try lisinopril or ramipril. And if that is still a problem, then you can look at a completely different class, like ARB, for example, androgen receptor blocker, as a suitable alternative to treat with that side effect. I value your opinion on how we can help you. What do you think about this plan? Would you be willing to try? So again, this is about mutual decision-making, respect for patient autonomy. And so you involve the patient by giving them choices, incorporating them in their own management, being part of the plan and suggesting rather than instructing them about how to go about changing your lifestyle or or complying with prescribed therapy. All right. Before you end the consultation, it's very important that you summarize the encounter. And the best way to do this really is to ask the patient what they understood from the talk today, or ask them about any questions or anything they're unsure about. So sometimes it's easier for the patient to summarize rather than you to go recalling everything that was discussed. So ask them what are the salient points they learned from the consultation today, and then you could then bring to their attention or draw to their attention any glaring omission. So, for example, they may have told you that when we spoke about the need to be compliant with my medication because the condition is chronic, I need to take my medication every day. But they may have forgotten to say the lifestyle changes that are part and parcel with that. So I said, yes, that's very important that you need to take your medication every day. But you recall that we spoke about changing your diet and eating more fruits and vegetables and less sugars and exercising more regularly in order to improve your glycemic control or your control of your blood pressure. And perhaps the very last thing you must do is arrange follow-up after summarizing. You can't just leave the patient hanging. Once they have agreed to a mutually acceptable way forward, then there's a need to close the interview by asking the patient to come back for a review or to contact you if they have any further questions. So usually you'll say, well, I'm glad that you understood what we've discussed. I look forward to you implementing the changes we agreed on. And I'd like to see you back in a month to review your control of your hypertension or diabetes or whatever. All right. So this is basically, students, the crux of chronic disease counseling. I tried to find a YouTube video that exemplified it in principle, but haven't been able to so far. If anyone finds a video that they think is suitable, they could always send it to me. Are there any questions about counseling a chronic disease patient? I also posted a checklist that we use to assess patients and students' encounters related to chronic disease counseling. So I'm not looking for any questions related to all right, if no questions, I haven't seen Dr. Clapperton come online yet, but I'll make her a presenter and ask her to take over as soon as she joins. Any questions so far about the forum posts, about the responses, about the rotation? Catherine is asking, what is the next step in working with a patient who is consistently non-compliant even after having spoken to them several times? So Catherine, that's a good question. Thanks for it. You'll find that there are a few patients that are quite stubborn, and but there usually exists some reason for them being non-compliant. Else they wouldn't really come back to be followed up, right? I don't think patients will waste their time to come to the health centers repeatedly to only find out that their blood pressure, blood sugar is not where it should be without them having at least some intention of improving it. So very often, Catherine, these patients, there may be some misconception about the chronic disease that you're trying to treat. And you really have to dig deep and find out, based on their disease and illness experience, where that misconception may lie, or it may be that they had an unpleasant experience in the past with a physician or a nurse and have become quite cynical, and you might need to do some do some pacifying to be able to regain their trust. Or it may be that they had some unpleasant side effect or some reluctance to take a medication based on a personal experience or some story shared by someone they listen to. And so you need to let them know that while that might have been that person's experience, it may not necessarily be the case for them. So they have certain levels of reluctance and certain, a lot of reasons why patients tend to be non-compliant. And that's why this process is so important, to be able to extract the real reason behind the scene. Sometimes it could be availability and cost. And so therefore you have to use your knowledge of what else might be available to offer them, more cost-effective or more easily accessible solutions to the compliance issue. Anybody else have any thoughts about that, or ever encountered patients or relatives that have been repeatedly non-compliant, and what the underlying issue might have been? So the OSCE really involves 3 stations based on the teachings and the communication skills. There's the OSCE for the clerkship, right? That you would have been imparted and taught during the clerkship. And it's similar sort of format to a year 3 OSCE, where there would be simulated patients in the offices, instructions be placed on the doors, and you'll be given 1 minute to read the instructions, and then 7 minutes inside with the patient, with the examiner scoring your interaction and assessing your competence in treating with the case. And so that's really what it involves there. It involves skills and teachings that would have been imparted during the rotation. 3 stations, you're really required to pass the OSCE in order to pass the clerkship. However, due to the COVID constraints, we haven't been able to convene an OSCE. It's not confirmed whether we would be able to offer it in November, because we don't know what the COVID situation will be at that point in time. And so therefore, if it is that it is not possible to have a face-to-face OSCE, there may be other options like online OSCEs through the use of breakout rooms and so on, but those details haven't been confirmed. Hope that answers the question. All right, any other questions? I know you all would have done breaking bad news and dealing with the angry patient. Remember, you have to do that little snippet or that little recording between yourselves, exemplifying the skills that you would have been imparted on the rotation. So you could use these lectures and checklists as a guide, and look forward to you practicing it and submitting your tips, because it's probably the next best thing that we could get if we can't interact with real patients. Sometimes there are websites that have useful videos and audio clips and so on. Feel free to share them with me so I could give you my opinion on them. I know Geeky Medics is one of them that is used, but usually they impart a certain clinical skill as it relates to maybe like examining an abdomen or a CVS examination or whatever. It's a little more difficult to find patient-centered consultation videos or true family medicine type videos. Right. Any other questions? All right. Let me just pause here and find out if Dr. Clapperton is having technical difficulties. I'll just. So Dr. Clapperton will join us in about 10 minutes. So we have about 10 minutes to chat. Any questions, concerns? I know that the my learning is a bit frustrating with this access being a problem for some of you all. So let's bear with the faculty where they try to fix that. For Tinnitin, what percentage does it need to be right? So good question. Generally, we less than 10% is acceptable, Shivani. Just remember when you run your document through Tinnitin, leave out the references because obviously it will pick up the references as already published articles. So you run it without that, and we're looking for less than 10%. Right. So try to keep it, concise to the point and based on the literature that's out there from an evidence-based medicine perspective. Right? Come up with a reasonable list of differentials. For some of the cases, it may not have a big list. It might just be one glaring or just a couple. Or it might not be so clear that one is definitely the case over the other. In such a case, you take one of the diagnoses that you think is reasonable and you discuss the management along that line. Right? So be sure to cite the references and run it through Tinnitin and aim for a similarity index less than 10%. Have any of you all used Tinnitin before? Right, so Annalise is saying yes, right? So hopefully it wouldn't be too difficult for you all. Was everybody able to see their grade posted on my e-learning for the actual presentations? No, we generally don't give breakdowns. Janani is just 2%. If you're really interested, you can email Dr. Motilal, but generally we do go into our breakdown for these presentations. Annalise, you should be able to access it on your My Learning account. All right, so I'll just make any change online here regarding the shift from Wednesday, the 17th to the 24th in the afternoon time. Right, so you'll see Miss Joseph, she normally talks about a family study, right? So she discusses the family dynamics at play as related to the social circumstances that impact on health or the social determinants of health. And your predecessors would have had to do a family study that examined those determinants and presented to her. But of course, based on the COVID-19 restrictions, we're not able to allow you all to interview the families. And so she'll be doing more of a didactic presentation on the family study. So just wanted to clarify that. So that will be from 1 to 3 p.m. next week, Wednesday. All right, so Dr. Clapperton just joined. So let me stop sharing my screen and make Dr. Clapperton a presenter, if you find me. Maria Clapperton. So Maria, if you can hear me, I just made you a moderator. So you should be able to take the floor and share your screen.
All right, let me see. Good afternoon, everybody. Share. Oh, I'm trying to share my screen, but I'm seeing share application is still not available, Dr. Khan.
Maria, I actually, I think I hear you now. Are you able to share your screen, Maria?
I'm trying to. I'm not seeing the option being available.
All right.
Let me try another browser.
All right. Okay. Just checking. A media moderator, so you should be able to share the screen as a moderator. Let me see. I think right. I think it might have to do with your connection, but try now.
Okay.
Yeah, right.
No.
No? All right, let me see if I make you a presenter instead if that makes a difference. Let's see.
Okay.
Try now.
It's still unavailable. Oh, there.
Still unavailable. That's
Yeah.
strange. Let's see here. Make caption. So you're not seeing anything by the purple
It says share application.
tab
Right?
at the bottom.
Um,
Share application, right? Share content. Yeah.
yeah, it says share application and it says unavailable.
Not available. Strange.
Yeah.
Um,
Share content, share files, not screen.
so you're seeing any and you're seeing something next to the little gear button next to settings. My settings. You're seeing like the square with the arrow in it.
Yeah. Yeah, and my
And when you
options
click on that, what
are
you see?
share
Right.
blank whiteboard, share application, and that's
Right.
unavailable.
All
Share
right.
camera and share file.
And when you click on that, right. So when you share application, what you see?
I can't share application. It says
Wow. Okay.
unavailable.
That's strange.
Yeah.
Hmm.
So I am
Wow.
on Safari, so I'm gonna try Google Chrome.
The other thing you could do, Maria, if you could share your camera, what
I
you
can.
could do, you could
Yeah.
actually, you can,
Yeah.
because they have the PowerPoint was uploaded to their My e-learning. So if you want, you could do it
Go
from
through.
there. Or if you want to try a different browser, you could do that. What you
Yeah, let me
prefer?
just last try here and then I will go that way. Try
No
this.
problem. Okay, let's try the other browser and see.
Yeah. Right. Okay. Do I have to, let me log out and come back in. I'm gonna log out and come back in. Hello? Right. Can you hear me?
Yeah, Maria, loud and clear.
Right, so I can share my screen now.
Oh, that's great. Let's see.
Yes.
All right. I think I need to share.
I don't have 1,000,001 screens.
Ah, yeah, I think you're at your last slide there, Maria.
Let me see.
All right, so let me just introduce her. By the time, everybody, this is Dr. Clapperton, who's going to teach you all on managing hypertension in primary care. She's one of our DM graduates and an active member of the Caribbean College of Family Physicians. Maria, what is your role there again? President?
I'm the
chapter?
president of Trinidad.
President of Trinidad chapter, right?
Yes.
Right, CPFP, right. So we're quite privileged to have her here this afternoon. And you okay there, Maria? You ready to take the floor?
I am. Can you see my screen properly? You can see the presentation.
Yes, I am, yeah.
Okay. Well, I can no longer see the chat controls and so.
Oh, all right. So what they probably could do, can somebody try to, let me raise my hand and see if you could see that, if I raise my hand.
Uh-huh.
Can you see me raising a hand there, Maria?
I will have to minimize the right. No.
All right. Well, what you probably could do, Maria, if your chats don't, well, actually, I am seeing your chat, yeah, I am seeing your chat as well as your
I can see
PowerPoint.
the trending and I can see the chat now. Yeah. Okay.
Oh, you see it? Right, okay.
Where is your hand raising thing coming up?
Let me see you try again.
Oh, there, I see it. It's working now.
Right. Right.
Good. I
Right.
think I'm all
Shall I
set.
lower it?
Yeah. Thank you.
All right, so students, enjoy your session here with Dr. Clapperton, and I'll see you guys later on in the week. I'll probably come in and have a chat with you guys. Take care, bye. Oh, Maria, I forgot to mention that all the lectures are recorded for those students who might have internet connectivity challenges or unable to join us live. So it will automatically stop recording when you finish, and I'll post a link for them afterwards.
Okay, good. Thank you,
See
Dr.
you.
Khan.
Okay. See you.
Good afternoon, everyone. Hello. I see. Okay, so just to continue from Dr. Khan's presentation, I'll be presenting on the management of hypertension in primary care. And I normally start with a role play session. And so I'm going to try to see if we can do that here this afternoon. So we can just practice. I will be the patient and I need a volunteer to be the doctor. So you can raise your hand if you want to volunteer to be the doctor, and I think it's possible to unmute your microphone to participate. So can I have a volunteer? Nobody? Anybody want to volunteer to be the doctor? I'll be the patient. I'll pick somebody. Okay. Can you let me know if it's possible for any one of you to unmute your microphone to participate? Or is that not an option available? Okay, thanks, Daniela. Okay. So Daniela, would you like to be the doctor? Okay, so just unmute your microphone and we'll start. Hello?
Hi, good afternoon.
Good afternoon.
Okay.
Yeah. So Daniela, right?
Seeing my screen though, I'm getting a connection problem, so I can't see anything. I don't know if you have a slide showing.
Okay. It's just a slide up, but you just need to, it's just a conversation at this point. So we won't be starting the slides anyway.
Okay, so there's no slide.
No. So, yeah. We won't need the slides until we're finished.
Sure,
So the clinical scenario is that I'm a 45-year-old female and I've come to the health office of your health center to get a food badge medical document completed. And the nurse at the front, the screening nurse, has taken my blood pressure and it was found to be 135/90. And they've just sent me in to see the doctor. And I'm sitting in your office and we're about to start the consultation. Okay. So let's take it from there, right? 135/90.
Okay. And you're 45?
45. Yes.
Okay. You ready?
Yes. So good afternoon, doctor.
Hi, good afternoon. How are you today?
I'm good, and you?
I'm fine. Can I have your name, please?
Mary Clark.
Okay, Miss Clark. Can I call you Miss Clark?
Yes, sure.
Okay. And what is your age?
Sorry?
What is your age?
45.
Okay. So how may I assist you today? What brought you in today?
Well, I came to get a medical for my food badge. I'm trying to renew my food badge. I came to do a medical. So I'm here to see you and get the document signed up.
Okay. All right, not a problem. Let me just have a look at the medical, okay? What the nurse did. Oh, okay. So I'm seeing your blood pressure is a bit elevated. So, are you on any blood pressure medication?
No, I'm not on any blood pressure medication.
How are you feeling today?
I feel fine. I just came to do my medical and leave. I'm accustomed. This is the second time I'm doing the medical. Do I have high blood pressure?
If you have,
Is there something wrong with my blood pressure?
well, it's a bit elevated. So I would like us to monitor it. But the last time, when was the last time you checked your pressure?
About 2 years ago.
Okay. And was it normal?
Well, yeah, I think so. I think it was normal. They didn't tell me anything.
All right. Okay. And you said you you sell food.
Yeah.
That is your occupation.
Yes. I work in a fast food outlet.
Okay. Do you have any family members with high blood pressure?
Yes, my mother, my grandmother, my uncle, a few uncles, and an aunt.
All right. Do you feel ill at any times, like headaches or any problems, blurry vision, anything like that?
No, I feel fine. I don't have any symptoms of anything.
All right. Do you have any questions for me?
Well, do I have high blood pressure or something? Do I have to go on tablets?
Well,
I mean, I know you mentioned that my pressure was high, so I'm a bit concerned now
okay.
about what's happening with that.
Okay, so let's talk about high blood pressure, okay? So your bottom
Yes.
number, which is the diastolic number, it is high,
Mm-hmm.
and which is 90. And your systolic number, which is the top number, it is almost close to the number of being high blood pressure, which is 140 versus 135. So we can say you do have high blood
Yeah.
pressure, but high blood pressure, it could be managed with medication and lifestyle modifications and treatments. So for now,
Okay.
yeah. So for now, how do you exercise or anything like that?
Well, I mean, I do a lot of walking for work.
Mm-hmm. Okay. And what is your diet like?
Normal. I mean, I
What is
try to have vegetables every so often. I mean, I do eat fast food though. I know I've been trying to cut back on the junk food, but
Okay.
I still find I consume a lot.
Oh, okay. So I would like you to lower your salt intake and try to eat more vegetables as well, and try to cut down on the fast food a bit. And also, I would like you to come back for a follow-up. I also like you to exercise. I would like you to come back for a follow-up because you said you have hypertension in your family.
Mm-hmm.
Okay. Since it's almost high, I think I should uh, prescribe a medication for you
Okay.
now. So I'm going to prescribe so beta blockers for you.
Oh, what's that?
So beta blockers, they would, I'm trying to remember the function of beta blockers. So basically it will lower the pressure. Okay, because you don't want the pressure to be high, because high blood pressure could lead to a lot of complications. So we need the pressure to go down a bit.
Oh.
Or
Okay, so
or do you want to modify, you want to change your lifestyle as in with diet and exercise? What do you want for now?
I have a choice, you mean? I could choose if to take the tablets or not?
I still want you to come back for follow-up. So
okay, when?
Next week.
Next week. Okay.
Yeah.
So in 1 week time. All right.
Yeah.
So I can choose if to take the tablet from now or to just come back in a week's time and see you.
But would you exercise and change your diet?
Well, I mean, what in terms of changing my diet, what would you like me to do within this time? And I mean, exercise. I mean, I do a lot of walking for work. So is there anything in particular that I should be doing differently? I don't know.
To increase the intensity a bit, so you could jog. Also, I like you to less salt. Stop eating fast food. Also,
I will try hard.
try hard. Okay. Do you have any questions to me?
So I have to be on these. When I come back, you're going to put me on tablets, or I mean, and if I start the tablets, how long I'll be on these tablets for? I mean, and you mentioned all these problems with high blood pressure, so I kind of worried now because I thought I was healthy.
Okay, so sometimes patients, when they take their blood pressure in the hospital, their pressure goes up. It's called white coat hypertension. So I would like you also, if you can test your blood pressure at home, and if it's still high and you're doing things differently, then you'll come back to me and we will go over medication. Because I don't want to prescribe something now and just white coat hypertension you're experiencing. But you said hypertension is in the family.
Yes.
Yeah. So I want you to go home, change your lifestyle, and test your pressure say next 2 days. And if it's still high, come back to me and we will talk about medication and further treatment.
Okay. So you want me to come back in 2 days or in a week?
Come back in 2 days.
2 days time. Okay.
Yeah.
All right. No problem. Thanks, Doc.
Okay, no problem. You have a safe journey home, okay?
Okay, I'll see you in 2 days' time.
Okay. Take care.
Okay, good. All right, so you can go back to unmuting your mic, Daniela. Thank you very much. So, you know, it's one thing to talk about managing hypertension. I know Doc would have gone over the communication skills and so it was just a little role play exercise to kind of consolidate what you've learned in the communication skills session and now moving forward in terms of what to do with the patient who is presented with an elevated blood pressure, right? So I just want you to keep in mind the clinical scenario that we just role played, and then I'll move into the presentation. And as we do that, Daniela and all the other attendees, we can, adjust to suit and, improve on your communication skills and also your management approach, right? So let me know if you have any questions and we will start the presentation. Right. Can you see my screen? Right. Okay, so In today's presentation, we'll start with the epidemiology, risk factors, classification, pathophysiology, a little bit about screening and diagnosis, and then primary care management of hypertension. And we will speak about resistant hypertension, special considerations, and the WHO's response with the HEART initiative. So I have a definition of hypertension here, but it's a very simplified one. And the reason why I've chosen this one is because we all know what hypertension is, but we tend to have a bit of a challenge when trying to break it down into simple terms and explain it to our patients. So I've just given you one here so that it may make it a little easier to explain to the patient. So what is hypertension? Blood pressure is the force exerted by circulating blood against the walls of the body's arteries, the major blood vessels in the body. Blood pressure is written as two numbers. The systolic, which is the pressure in blood vessels when the heart contracts or beats, and the diastolic pressure in the blood vessels when the heart rests between beats. Hypertension is when the blood pressure is too high. So an estimated 1.13 billion people worldwide have hypertension, and most or 2/3 of them living in low and middle income countries. In 2015, 1 in 4 men and 1 in 5 women had hypertension. Complications from hypertension accounted for 9.4 million deaths worldwide each year, and fewer than 1 in 5 people with hypertension have the problem under control. It is a major cause of premature death worldwide. One of the global targets for non-communicable diseases is to reduce the prevalence of hypertension by 25% by 2025. So we have about 5 years again to reach this target. Globally, the overall prevalence of a raised blood pressure in adults aged 25 and over was around 40% in 2008. A chronic risk factors survey conducted in Trinidad and Tobago by the Ministry of Health in 2011 revealed a prevalence of high blood pressure of 26%, 29.8% in males and 23.1% in females, or 1 in 4 persons. Detection, treatment, and control of hypertension is an important health priority worldwide. At the global level, it is estimated that people with hypertension, of these, only 57% know of their condition. 40.6% of them receive antihypertensive drug therapy, but only 13.2% of them actually achieve control of their blood pressure figures. So with respect to hypertension, we'll look at modifiable and non-modifiable risk factors. But non-modifiable risk factors are the ones that we really can't do anything about. So there's age over 65, African heritage, family history of hypertension, coexisting chronic conditions, for example, renal disease, diabetes, and sleep apnea. And then we have modifiable risk factors. These are the ones we would spend time on because we tend to spend a lot of time counseling patients on how to adjust their lifestyles based on these risk factors so that they can, lower their chances of developing cardiovascular complications in the long run. So unhealthy diets high in fat, high in sodium, low potassium, a history of physical inactivity, excess consumption of alcohol, smoking tobacco, being overweight or obese, and high levels of stress. With respect to the etiological classification, we can divide hypertension into 2 major categories: primary or essential hypertension, or secondary hypertension. And primary or essential hypertension is found in the majority of patients, approximately 95% of them, who have no specific cause identified, whereas secondary hypertension occurs in few cases, and this is where the hypertension is due to an identifiable cause. This slide shows an overview of the various causes of secondary hypertension, and they may be further subclassified into the following. Kidney diseases, for example, renovascular hypertension, medical conditions, endocrine and conditions, for example, Cushing's syndrome, pheochromocytoma, thyroid disorders, for example, hypothyroidism. Other possible causes include sleep apnea, obesity, pregnancy, medications and supplements, for example, birth control pills, cold remedies, over-the-counter pain relievers such as NSAIDs, and some other prescription drugs. Let's not forget illegal drugs such as cocaine and amphetamines. In this slide, it just highlights some of the secondary causes of hypertension on the right, and to the left are some of the clinical points that may cue you in to a possible underlying secondary cause for the hypertension, and you know, may lead you to take a closer look at that patient. For example, a patient with obstructive sleep apnea may be an obese patient with a history of loud snoring and excessive daytime sleepiness. So if that patient presents with an elevated blood pressure and these clinical cues, you may want to consider the obstructive sleep apnea as a potential secondary cause for the hypertension. A patient with a pheochromocytoma, you may see, you know, the patient may present with headaches, diaphoresis, palpitations, tachycardia, and paroxysmal hypertension. So you can go through the list of the others, but it's just an idea, just to keep in mind, not to miss it, should you pick up any of those. This table shows some of the drugs that may elevate our blood pressure. Some you may already know and some may be surprising. So just pay attention to this list of medications here as well. So suspect secondary hypertension if there's a young patient with an early onset in childhood or adolescence, especially if there's an absent family history. If there is severe or resistant hypertension, and we'll go into the definition of resistant hypertension later on. If there's an abrupt worsening in the blood pressure in a previously well-controlled patient, if there are any clinical features of an underlying disorder in association with an elevated blood pressure, and we've gone through some of the clinical features in the previous slides. So this busy slide, it's an algorithm showing you, it's just to help you in terms of the evaluation of a patient who may be suspected of having a secondary cause for their hypertension. And it's broken down according to age and, you know, which investigations may need to be conducted to narrow down and pinpoint, you know, the secondary cause for the hypertension. So other types of hypertension. There's malignant hypertension, where there's a very high or rapidly rising blood pressure, which threatens end organ damage and requires urgent or emergency treatment. About 1% of those with essential hypertension develop malignant hypertension. Resistant hypertension may be diagnosed if the blood pressure is uncontrolled on 3 or more hypertensive drugs. On this slide, we talk a little bit about the pathophysiology of hypertension. So on the left, stress may trigger a sympathetic nervous response, which stimulates the heart rate. You have increased heart rate, increased cardiac contractility, increased vasoconstriction, which leads to 1, an increased peripheral vascular resistance, and 2, increased cardiac output. And together with increased cardiac output and increased peripheral vascular resistance, we have an elevated blood pressure being recorded. And there's also, you know, renin, the renin-aldosterone angiotensin system. And it's key to pay attention to the pathophysiology of hypertension, because the medications that we use to manage hypertension, they act on different points of the pathway. So it's good to understand the pathophysiology. So renin released by the kidneys, angiotensinogen now acts to form angiotensin 1, which is then converted to angiotensin 2, which triggers arterial constriction and increased peripheral resistance. We also have, and this is the pathway in which the ACE inhibitors will work, and we have the increased aldosterone secretion, resulting in increased retention of sodium and water, and therefore an elevated blood volume. So the increased peripheral vascular resistance and increased blood volume will also result in an elevated blood pressure. So we'll pay attention to the picture on the top right. So normal blood vessel, and the kind of vasoconstriction we'll see to the right of it in hypertension. So with respect to screening, one of the challenges we face as physicians and counseling patients or managing patients with high blood pressure is that it's asymptomatic. It's nicknamed the silent killer. Most of the patients, if not all of them, they feel fine. They walk around and they have, they're able to perform their usual duties until we do check their blood pressure, and we may be surprised to find a patient walking around feeling fine with a blood pressure 100 over 115. And the patient has said, well, I've never gone to the doctor, I've never checked my blood pressure, or it's been years. And that person is probably saying, well, I'm fine, I have no medical conditions, I'm healthy. And this is potentially dangerous because these high pressures for a prolonged period of time can cause end organ damage, and it's only when we have complications of such then the patient falls ill and maybe ends up in hospital and other undesirable consequences. So it's good to ensure that we check the blood pressures and include it as a routine part of every healthcare encounter for adults. It's good to get the patients in the habit of knowing their numbers and to monitor blood pressures, especially frequent monitoring in the patients who are at high risk for developing hypertension. When checking and managing patients with high blood pressure, it's good to do two things. Check your device that you'll be using to make sure that the readings you're recording are accurate, and your procedure, make sure that you're measuring it properly. So with respect to the instruments, you have the manual mercury sphygmomanometer, which is considered to be the most accurate way of measuring the blood pressure. However, it can be potentially toxic if the mercury is split. And we have more commonly available now the electronic devices and the home blood pressure monitoring devices. I've put here on this slide in particular just to bring to your attention, especially with the influx of these really available instruments now. There was a study conducted in 2009 and it was found that 30% of 554 home blood pressure monitoring devices were validated, and 72% of them were found to be inaccurate. So you'd really want to know that the device you're using is measuring an accurate blood pressure. So they're now trying to generate a list of validated devices. So I've included a link here, and it has a list of validated devices. So check the make and model number of the device and see if it's a validated device. So it's important to make sure that you're using an accurate device. In terms of measurement of the blood pressure, we all have a fair idea as to how to measure the blood pressure. But just some key points to note with respect to the client, the cuff, the procedure, and the readings. Care should be taken to make sure that the client is as comfortable as possible, alleviating any factors that could raise the blood pressure. Allow the client to sit quietly for 5 minutes before the blood pressure is measured. Cuffs of varying sizes must always be available and be kept in good condition. The first and last audible sounds should be recorded as systolic and diastolic pressures respectively. Measurements should be given to the nearest 2 millimeters of mercury, and readings should be taken at least 2 measurements, 1 to 2 minutes apart, and reported as the mean of 2 readings that do not differ by more than 5 millimeters of mercury. This table shows the American Heart Association recommendations for the measurement of blood pressure, that procedure. Just some other points to note. Make sure that the patient is seated comfortably with the back supported, legs uncrossed, and the upper arm bared. So you're not putting the cuff over their clothes, ideally. The patient's arm should be supported at the heart level. Neither the patient nor the person taking the measurement should be talking during the procedure, right? As they say on the right, talking during the procedure may cause deviations in the measurement. So these are some points to note. Out of office blood pressure monitoring. So this is to make you aware that there is such a thing as ambulatory blood pressure monitoring, and there are ambulatory blood pressure monitoring devices which can be worn by the patient over a period of 24 hours, just like how we do 24-hour Holter monitoring. They put on this device for 24 hours, and it serially measures the blood pressures. Their readings at home, record them, and bring them in to the clinic when they come back to see the doctor. So screening for hypertension and also maybe very handy when we're trying to assess patients who may present with white coat hypertension or white coat effect. So making the diagnosis. The diagnosis of hypertension must be established by a doctor, physician assistant, or nurse practitioner. The latter two we don't commonly have widely available in Trinidad, but at least by the doctor or the senior nurse in the clinic may make the doctor aware of the patient. A diagnosis of hypertension is not usually made on the basis of only one elevated blood pressure reading. This is usually done based on at least 2 readings taken from the patient, and it must be done on 2 different occasions, 2 different days. So it's not 2 readings from the same patient on the same day. So it's a reading from the patient on the first visit, and then if found to be elevated and the patient is not known to be hypertensive, you bring back the patient for a repeat visit and to have their blood pressures checked again, and if it's still elevated, we can make a diagnosis of hypertension. So this slide shows the comparison of the various diagnostic thresholds, which due to the different committees presenting the guidelines, there may be, or there could be some confusion. On the right, this classification is created by CAFA. These are our Caribbean guidelines. So you probably want to get familiar with these. The ones on the left are the GNC 8 criteria, and you also have the American Heart Association numbers listed in the table as well. So they're basically similar with one or two points to note in terms of the way they define stage 1, stage 2, and the CARFA guidelines have a stage 3. So you can pay attention to these, but if you are quoting, you can mention where you've gotten it from. So you can say, these are the CARFA guidelines, as opposed to these are the being from GNC 8. Again, this slide highlights what the GNC 8 criteria are, so you can get familiar. And again, stated here, this classification is based on the average of 2 or more readings taken at each of 2 or more visits after initial screening. This table shows some signs of end organ damage. So we would look out for these things and assess the patients when we see them in clinic for any signs or symptoms of end organ damage, which may affect the heart, brain, kidney, eyes, or vasculature. So with respect to the heart, you may feel displaced or thrusting apex beats. There may be left ventricular hypertrophy on the ECG, angina or prior myocardial infarction or congestive heart failure. There may be a history of a transient ischemic attack or stroke, proteinuria or elevated blood or creatinine levels, and signs of hypertensive retinopathy, of which there are 4 grades. So it's good to recommend that the patient, to assess the patient, and also recommend that they have a full eye exam to check for any signs of hypertensive retinopathy. Vascular system, so if there's asymmetrical, absent, or irregular pulses on examination. Diagnosis of labile hypertensives will show fluctuation of blood pressure from normal to stage 1 or higher hypertensive ranges, and such patients should be monitored regularly. Persistence of diastolic readings above 90 will usually indicate established hypertension. Then there's isolated systolic hypertension. This is diagnosed where there's an average of 4 readings greater than or equal to 140 on top, and on 2 occasions with a diastolic blood pressure of less than 90 millimeters of mercury. Isolated systolic hypertension should be carefully re-evaluated at intervals. And as we've been mentioning thus far, white coat hypertension, and this may occur in patients whose blood pressure is raised only in the clinical setting, but not at other times. A white coat effect may further raise blood pressure in a patient with hypertension, right? So we can look out for these other variations. And in terms of management, we start with the history. And this is, it just ties in everything that we spoke about before, and looking out and assessing the patient for any risk factors, whether it be modifiable or non-modifiable risk factors. So we start with patient demographics, history of risk factors for hypertension or cardiovascular disease, any history of, and we look for any possible signs of end organ damage, strokes, TIAs, ischemic heart disease, and signs of peripheral vascular disease, for example, intermittent claudication, pain in legs on walking, and the drug history, especially for medications that may lead to an elevated blood pressure, such as oral contraceptives. Patients with osteoarthritis may be using NSAIDs or steroids or any other alternative therapies. History of adverse reactions to antihypertensive drugs. It's significant to note that. Any family history of hypertension and its complications, diabetes, coronary artery disease, renal disease, and hyperlipidemia. And in the examination, pay special attention to the measurement of the blood pressure. Make sure that it's accurate. Measurement of weight and height to determine a BMI. Measurement of waist circumference, which can also help us in the assessment of patients who are at risk for cardiovascular disease. Characteristics of the pulse, including the carotids and bilateral pulses and radiofemoral pulse delay in coarctation of the aorta. Location and character of the apex beat to assess for left ventricular hypertrophy. Examination of the eyes using fundoscopy, and examination of the abdomen for renal masses or bruit or abdominal aortic aneurysms. Signs of anemia may indicate chronic renal disease. So with respect to investigations, we will do a urinalysis to check for protein, microscopy if possible. In terms of the blood investigations, we would look at the creatinine, electrolytes, fasting lipid profile, and a CBC. Also, the fasting blood sugar. And in terms of your cardiovascular assessment, we'll do an ECG and a chest X-ray. Please note referral for additional investigations may be required for patients with resistant hypertension and those suspected of secondary causes of hypertension, or to further assess for any targets and organ damage. So management, non-pharmacological management. So we always should start with counseling patients on the modifiable risk factors. So diet and exercise, conservative management. We should always, even if we are placing a patient on medication, we should always start with counseling them on what they can do to help themselves, which is diet and increase their levels of physical activity. And when we say diet, we don't necessarily mean to starve or to cut out completely, but by that we mean to encourage a patient to be more mindful and make more healthy food selections and increase their levels of physical activity. So in terms of hypertension, there's a well-known DASH diet, dietary approaches to stop hypertension plan. The DASH diet, which basically addresses it's a low salt diet. So you advise the patient with respect to limiting the use of salt to less than 2.4 grams, no added salt in cooking or at the table, limit the use of, or avoid if possible, the use of canned food and salted meats, which, you know, in our Caribbean population, our foods are frequently rich in salt. So advise them to pay attention when they're grocery shopping to read the food labels and select products that may be low sodium, and also limit their use of added salt at the table and when cooking. Reducing excessive dietary fat to no more than 30% of the calories. Saturated fat should not exceed 10% of the calories, and ensuring intake of fiber of at least 30 to 40 grams per day. Ensuring intake of potassium. This can be achieved by good selection of fruits, vegetables, especially bananas, tomatoes, and oranges, as well as coconut water. Take-home point here is to encourage the patient to increase their intake of vegetables, cut down on their intake of salt and high-fat foods, and be more mindful in terms of, you know, the foods that they're selecting to eat. So healthy food choices and portion control, right? So it's not a list of, you know, don't eat this, and, you know, some patients may misinterpret the word diet to mean to starve themselves and restrict their caloric intake. It's not that. So this table goes into more detail with respect to the DASH plan and servings per day. And other things that we can do in terms of counseling the patient on lifestyle changes would be to counsel them on increased levels of physical activity. So activities of moderate intensity. It should be an activity where while doing it, they should be able to hold a comfortable conversation. So it should make them puff and pant and have the heart rate up. So moderate intensity physical activity. Sustain for at least 30 minutes daily for at least 5 out of the 7 days a week, which will result in a total of 150 minutes per week. Walking is the easiest form of physical activity that we counsel the patients on. Weight management, so dietary counseling and counseling on physical activity will come in handy here. Reduction of alcohol intake. So with respect to alcohol intake, should not exceed 2 drinks for a male patient in any one day, or 1 drink in any one day for a female. And 1 drink is stipulated as 1 ounce of spirits, or 1 bottle of beer, or 1 glass of wine. It does not mean an entire bottle of something. And it also doesn't mean that they get to accumulate their drinks for the week and have them all on the weekend. That's binge drinking, and that will defeat the purpose. It might actually increase the risk of cardiovascular disease. So it's in any one day. And cessation of tobacco use, so smoking cessation for those patients who are smoking, to counsel the patients. And education. Every opportunity should be taken to educate the patients, clarify any misconceptions, talk to the patient and their relatives. For example, if your patient is a male patient, you may find out who cooks the meals in the house. So if it's the wife who's doing the cooking, you would like to include her in the consultation, include her in the conversation with the patient's permission, of course, and, you know, advise her and counsel her on, you know, a low salt diet and all of the other elements of the healthy diet, and counsel the entire family, not patient, on ways to increase their levels of physical activity so that they can do it together. And it's a way of making sure that all members of the family are eating healthy and increasing their levels of physical activity. And this will help to motivate the patient themselves to do what they need to do, because what we're trying to do in essence is encourage behavior change. And we have to recognize that this is not an easy thing to do. It's lifestyle change. It will take some time. So we have to continually reinforce and remind the patients as we go along every time we see them. So with respect to pharmacological management, so this slide shows, it's a very busy slide. It shows an algorithm for managing hypertension and the use of certain drugs. So in the top right section, it mentions the initial drugs of choice for managing hypertension, which would be the ACE inhibitors or the ARBs, angiotensin receptor blockers, thiazide diuretics, and the calcium channel blockers. Right? So there are different strategies. You can start with 1 drug, titrate to, this is more commonly used at this point in time, start with 1 drug, titrate to the maximum dose, and then add a 2nd drug. Or other people may start with 1 drug, then add a 2nd drug before achieving the maximum dose of the first. And the 3rd option, which is what you'll see being utilized in the HEARTS algorithm, to begin with 2 drugs at the same time as separate pills or in fixed combination pills. Initial combination therapy is recommended if blood pressure is greater than 20 or over 10 millimeters of mercury above your goal. So again, you'll have your targets in mind for your patient. And please note that at each point, it's highlighted where we reinforce lifestyle and adherence to medication and to continue treatment and monitoring. So your clinical consultation, your review of your patient, it's not to ball up on buff the patient every time you see them because you're frustrated telling them take their medication, why you're not eating right and exercising. Again, it's for us to understand that it's behavioral change. We have to be patient. And it's really not worth it for you because if you quarrel with every patient that comes through the door, by the end of the clinic, you'll be frazzled with an elevated blood pressure yourself, you know. And it still mightn't ensure that the patient has listened to you. So it's better to take an approach where we're understanding that we're trying to do something to encourage a patient to change their lifestyle, and it's something they've been doing for years on end, and it will take some time, and we have to keep checking in with them and remind them about, little changes that they're supposed to be making, and motivating them and encouraging them to do so. So it's us helping them. So it's help me, help you, that kind of approach. And encourage them to, the more they do on their own to eat healthy and increase their levels of physical activity, etc., will help to naturally lower their blood pressures, and we may require less, if not no, medication in the long run to help control their blood pressures. So that's something we can encourage them to do to keep them motivated, and also to keep checking that they are taking their medications as prescribed, and we'll go into that in more detail later on. So this slide shows some of the special considerations. For example, in pregnancy, do not use any ACE inhibitors. More commonly used would be methyl dopa as first line here, and then nifedipine. And in the other cases with the diabetics, ACE inhibitor, ARB, a calcium channel blocker, and a diuretic. We have these selective beta blockers as well. So this slide shows the proposed HEART algorithm, and this is a standardized treatment protocol for hypertension for Trinidad and Tobago. And it's the whole idea of this algorithm is so that we have a streamlined, straightforward, simple, easy to follow algorithm that doesn't have any branches, right and left, and too many options, so that everybody will be on the same page, and so that not only the physician but that the patient, if we put it up in the clinic, will be able to follow and know where they are in terms of their treatment. So why do we have two? So we have a preferred and acceptable algorithm. The preferred algorithm for Trinidad and Tobago was designed based on best practice, and however, some of the medications were not readily available. So while they are sourcing the medications and making these more mainstream, we have the acceptable algorithm that contains medications that are more widely available in the public health system. So eventually, they would like everyone to accept this algorithm of managing hypertensive patients, not only in the public sector, but also in the private sector. So very soon we'll talk a little bit about, that HEART initiative and what's been done in Trinidad so far. So if you look on the right, you start with an ARB, irbesartan 150, or candesartan, which is available at this point, 16 milligrams, and you add, so it's a combination therapy to start with. You add a calcium channel blocker, it's amlodipine 5 milligrams, and then if the patient is still uncontrolled, not meeting a target within a month, you move up to the next step and you double the ARB, and you increase the calcium channel blocker. The amlodipine goes from 5 to 10. And if still uncontrolled, you move up to step 3. And this is where they're adding a thiazide, or adding a diuretic. And step 4, if still uncontrolled, we move to step 5 to refer the patient. So in the acceptable algorithm, we do have lisinopril widely available and the amlodipine. So you can start with that, and then as you continue to move forward, and they increase the ACE inhibitor all the way up to 40, and then 10 amlodipine. And in step 4, a diuretic is added, and if the patient is still uncontrolled, they're referred to for further management. Again, another reminder is made to avoid the use of ACE inhibitors and ARBs in pregnancy. So follow-up visits. Our patients tend to have the idea or the misconception that they just need to get their medication. They don't need to see the doctor. It's a waste of time waiting in clinic to see the doctor. Just go to the pharmacy and refill medications. But there is a purpose for that visit, and in that visit, we should be measuring and recording their blood pressures. Although it's good practice to advise the patients, the hypertensive patients, to get a blood pressure machine, check their readings at home, record it in a notebook, mark down the date and time, and walk with those readings every time they come to clinic and when they come to see you, so that you can trend their blood pressure readings and have a better idea as to what's happening with their blood pressures at home, rather than just relying on the one reading they get when they do come to clinic. Most of the times, the patients tend to forget to take their medication on the day they do come to clinic. So it makes it very difficult for you to assess on that day then what has been happening when they take the medication at home. And it makes it more challenging for you to decide whether or not or how to adjust their medication. So it's always good to advise them to monitor and walk with their readings. So you measure weight and height, assess their BMI, check for compliance with treatment, including taking medication the morning of the visit, like we just mentioned. There are all sorts of reasons. Doc, I was hustling to come to clinic, I forgot to take medication. Doc, I only take it when I eat, and I can't eat so early in the morning, so I usually take my medication later on in the day, so I haven't taken it yet. All sorts of things, right? Ask about symptoms or changes since your last visit and any adverse drug effects. Stress the importance of a healthy lifestyle. So always in each encounter, go over, reinforce, check and see, and even congratulate the patient for changes that they've made and improvements that they've made to encourage them to continue to do so, right? Check to make sure. A lot of patients don't know the names of their medications, and there may be issues there where, or the patient just may not be taking their medication at all. Sometimes you may have to ask the patient to come with all their medication next visit and put it out on the table and go through each one for them. So it's not the white pill and the pink pill and the red pill, but to actually show them that this one is lisinopril, this one is the nifedipine, this is how you take it, and also ask them to show you how they take their medication. Right? You'd be surprised, you may be able to clarify some misconceptions. Also, for the elderly patients, it's more challenging with all the different generics that may be available. And especially if they know the white pill, one drug may come as a white pill and a pink pill and a different brand. So that patient may not recognize that. And there have been instances where the patient is taking 2 sets of the same medication because they perceive it to be a different drug. So it's also good to make sure that the patient knows what they're on. So in terms of annual visits, you'd update the medical history, check for anything new that's been happening with the patient, measure and record blood pressure, check the BMI. Again, congratulate the patient if there have been any changes. Ask about lifestyle, diet, physical activity levels, tobacco use, alcohol use. And again, stress and reinforce the importance of a healthy lifestyle, do laboratory investigations, and do an ECG. Resistant hypertension is defined as blood pressure that remains above goal despite use of 3 antihypertensive agents of different classes, one of which should be a diuretic. Patients whose blood pressure is controlled with 4 or more medications are considered to have resistant hypertension. Patients with resistant hypertension are at high risk for adverse cardiovascular events and are more likely than those with controlled hypertension to have a secondary cause, which is usually at least in part reversible. So these are some causes of resistant hypertension, and in some cases it may be patient-related, just like what we were discussing before: misunderstanding the dosing, running out of tablets, illiteracy, unreported side effects. So some patients may take the medication, experience some dizziness, and just discontinue their medication without even letting you know. So it's good to check compliance. Distrust of the doctor, it's good to build that rapport so that, you know, the patient is more likely to trust you and listen to you if they trust you. Failure to modify lifestyle, white coat hypertension, unsuspected underlying causes, volume overload, high sodium intake. And then there may be due to doctor or prescription related causes. So due to failure to use large cuff on the arm, so errors in measuring the blood pressure, and medication related, so inadequate dosing, inappropriate combinations, no diuretic being prescribed, and using an NSAID. Commonly noticed for patients with osteoarthritis, you may want to substitute with paracetamol. And look out for steroids and other over-the-counter or alternative or herbal medications that may be impacting on the blood pressure. So medication compliance, we were alluding to this before. Again, clear up misconceptions. A well-educated patient is more likely to be compliant. So especially when you have a newly diagnosed hypertensive, take your time to explain what's happening to the patient and why they need to do what you're going to advise them to do, so that they're more likely to work with you, right? Also let them know that not because they're taking their medication and their blood pressures are looking really good and within normal range that they've been cured and they don't have it again, because some patients do that and then they just throw away the medication and probably don't ever come back to clinic. But let them know that, you know, when you're doing a really good job with, you know, watching what you're eating, exercising, and taking your medication, you'll notice good readings. And that's because you'll be well controlled. But it's good to still come back to clinic so that we could monitor you and do the necessary tests that have to be done on an annual basis. And, you know, also congratulate the patients. So non-compliance may be the result of several factors, such as medication side effects, absence of hypertensive symptoms. So, and this may cause a false sense of security. Again, it's an asymptomatic condition. So because they feel fine, they may feel like they don't ever need to take their medication again. So again, counsel the patients. Cost of medication, not too much of an issue for us, as a lot of the medications are available in the public health system and CDAP. Number of medications which a person with hypertension may have to take, and for that there are fixed dose combination therapies which may be costly and not necessarily available in the public sector. Alternative therapies, miscommunication, misunderstanding. So again, talk to your patients. Compliance requires a motivated patient, and you can do that by finding ways to encourage them. Again, making it a family thing in terms of eating healthy and increasing your levels of physical activity. So some strategy which may help by using, for example, fixed dose combination drugs and patient education. Withdrawal of drug therapy. So it's a good incentive to advise the patient that, you know, this may not be, you may not be stuck with the tablets for life. Help us help you. So the more that you do, the more work you put in on your part in terms of lifestyle modifications, then maybe in the long run, it may result in less medication being required to manage your blood pressures. And even we may be able to take you off of the medication. But again, let the patient know if we do take you off of the medication, probably see you back in clinic, not as frequently, but to review you with your home blood pressure readings just to see how you're doing and, you know, determine if you may need to go back on it depending on the changes. So again, withdrawal of medication, this should be done gradually and the patient should be monitored regularly and carefully. And patients who are young and who maintain a healthy lifestyle are more likely to be successful at this. Guidelines for referral: clinical suspicion of secondary hypertension or complicated hypertensives, patients with severe retinopathy, failure to respond to treatment, raised serum creatinine, hematuria, proteinuria, and I see there's suspicion of white coat hypertension listed here, but you know, don't go referring your suspected white coat hypertensives. Your specialists will call you very angrily, because that's something now, because these blood pressure devices are so widely available, we can counsel the patients and ask them to come in with their readings and we can have a better idea and manage them accordingly. Special groups as previously mentioned, please note hypertensive emergencies need emergency care. Do not try to drop a blood pressure quickly in clinic. And finally, the WHO response with HEARTS. So we spoke about the HEARTS algorithm. So just to tell you a bit of what the HEARTS initiative is about. In 2016, the WHO and the CDC launched a global HEARTS initiative to support governments to prevent and treat cardiovascular diseases. There are 5 technical packages. So HEARTS is an acronym that comprise the Global HEARTS Initiative, and the HEARTS technical package aims to improve the prevention and management of cardiovascular diseases, including hypertension detection and management. The 5 modules of the technical package include H for healthy lifestyle counseling, E for evidence-based treatment protocols, A, access to essential medicines and technology, R for risk-based management, team for team-based care, and S for systems for monitoring. So this provides a strategic approach to improve cardiovascular health in countries across the globe. And 5 countries have started implementing the HEARTS technical 15 countries have started implementing the HEARTS technical package. Barbados being one of those, and they have started to report some successes since implementing it. And also to mention that Trinidad and Tobago launched their HEARTS initiative in July 2019, but it's kind of ground to a halt now due to COVID, but will be back to the forefront again as it was being piloted at that time. And there are plans to scale it up. So by scaling up protocol-based management, improving access to medicines and technologies, and better measuring outcomes, successes are already being achieved and reported due to the implementation of the HEARTS technical package. So I thank you, and do you have any questions? Any questions? You can type it in the chat. Any questions, or can we end the session? Everybody okay? You can raise your hand if you have any questions. Not really in terms of importance, but yes, in terms of clinical significance and concern, yes, we will pay attention to an elevated systolic blood pressure. So we'll watch that patient more closely and manage the blood pressure. Any other questions? Everyone clear? Okay, good. Thank you, Shari. All right, so have a good afternoon, everybody. It was nice presenting to you all. My apologies for the technical difficulties. Took a little while to get used to, presenting online. Okay. Bye.